Thank you for your interest in my interdisciplinary strategy for restorative aesthetics. My name is Tomohiro Ishikawa, and I am speaking to you from Hamamatsu City, Japan. Today, I'll talk about tissue management to create optimal aesthetic results in severely compromised cases. I'm one of the founders of the training group 5D Japan, and in all of our education programs, we always emphasize the need for an interdisciplinary awareness. In our everyday practices, we are often confronted with scenes such as these. Patients' lives are strongly affected by these conditions. Using an interdisciplinary approach that includes appropriate examination, evaluation, diagnosis, and treatment is the key to achieve aesthetic and functional success. I will now speak about three-dimensional guided bone regeneration and soft tissue management. In a traffic accident, this patient had lost teeth from number 3 to number 7 in her maxilla and from number 20 to 25 in her mandible. The patient requested a fixed prosthesis, so we planned to treat this defect with implants. She agreed that to obtain an optimal result, it was best to simultaneously treat the defect and this malocclusion. If we had simply treated the trauma damage, the final result would have been a beautifully constructed malocclusal bite. This case demonstrates the need to consider all aspects of treatment before any one procedure is initiated. An orthodontic setup model was made, and diagnostic workshop was prepared for implant treatment planning. In multiple implant cases, we must mimic a natural healthy appearance by managing the surrounding tissue with abutments and superstructures. These are examples of multiple tooth and tissue loss cases. To achieve this kind of final result, we need to recreate a sufficient bone foundation. In this paper that my colleagues and I wrote a few years ago, we discussed the need for adequate regenerated hard and soft tissue when treating severely compromised aesthetic cases. In our group, we often use a combination of titanium mesh, resorbable membrane, and growth factors such as RHPDGFBB to three-dimensionally regenerate alveolar bone. With this patient, the numbers 30 and 31 area had limited bone volume. At the number 31 area, the bone height was less than 3 mm. In this condition, implant placement is completely impossible, so vertical ridge augmentation was necessary before implant placement. An implant was placed in the number 30 position, but the bone height of the number 31 area was not sufficient for implant placement. Bone-by-bone mineral and harvested autogenous bone chips soaked with PRGF was grafted over the entire area. A titanium mesh was placed over the site to create an appropriate three-dimensional ridge form. Please note that the mesh was not secured and does not cover the entire regeneration area. Two pieces of collagen membrane were placed to cover the site completely. After surgery, this periapical X-ray clearly shows the different translucency between the original bone and the grafted materials. 10 months after surgery, the mesh was removed and there was adequate width and height in the defect area with regenerated tissue covering the entire implant. After bone regeneration, the number 31 implant was placed with primary stability, and the bone sample was harvested during implant placement. The histology of the bone sample showed that we could successfully regenerate bone tissue. These X-rays are simply showing the condition of the number 30-31 area before and after GBR. This third X-ray shows the matured tissue with both implants placed in a stable environment. The number 31 implant is almost entirely supported by regenerated bone. We were still using a provisional restoration at this point, but you can see that with adequate hard tissue support, the soft tissue contours are taking on a natural shape. Using this case, I hope that I have shown that it is possible to regenerate natural bone with very simple GBR techniques, and that even regenerated bone alone is capable of supporting implant placement. I hope that you have already seen my video about titanium mesh GBR on Dental XP. This next case that I will show you is a continuation and results of that titanium mesh video. To quickly review the video, this slide shows the original deep defect with our target regeneration level at the yellow line. After implant placement, we use titanium mesh and collagen membrane to regenerate the defect and create long-lasting hard and soft tissue. Titanium mesh is cut and molded into the appropriate shape. Slits cut along the side of the mesh allow it to be shaped and adapted to the anterior arch. Titanium mesh can be a little difficult to handle, but using pliers such as these, it is much easier. When we place implants simultaneously, a 2 to 3 mm high temporary healing abutment is used as vertical support for augmentation. To avoid dead space, graft material should be packed inside the titanium mesh before placement. The process of placing titanium mesh over graft materials and then covering the entire site with collagen membrane is the same as the previous case that I showed you. 7 months after GBR, we could see a 3-dimensional ridge had formed underneath the removed titanium mesh. Due to using a coronary advanced flap, we usually do not have enough keratinized tissue for creating a healthy, natural-looking soft tissue contour. Soft tissue augmentation was used to compensate for this tissue deficiency. These images show the original condition in contrast to the final result. The patient had lost many teeth from a traffic accident, but through an interdisciplinary approach, I was able to achieve this satisfactory result and enhance her quality of life. Platform switched implants were used to preserve alveolar crestal bone. The final result shows a natural-looking tissue contour which has been maintained for a long time. This case was introduced in our paper in the Journal of Cosmetic Dentistry, World Cup Team Edition, edited by Dr. Maurice Salama. It is a more periodontally complex case than the previous two, but at its foundation, the team approach and the techniques used are the same. On the patient's first visit to my clinic, you can see the challenges that this case presented. She presented with an angle class 2 division 2 malocclusion. Pathological migration of a number of teeth had disrupted the integrity of the occlusal plane. Severe inflammation, bleeding on probing, and pus exudation indicated a very active disease state. The wear on the lower anterior teeth suggested that the upper anterior area had been damaged by parafunction. Before implant placement, orthodontic treatment was planned to correct the occlusal plane, to re-establish an angle class 1 canine-canine relation, and to secure adequate restorative space for teeth number 7, 8, 9, 10, 19, and 30. Of course, before orthodontic treatment can begin, bleeding on probing must be eliminated through initial preparation. The extraction of number 9 and number 10 was intentionally postponed to provide the support for an orthodontic wire and aesthetic reference. During orthodontic treatment, the patient underwent careful monthly monitoring and professional cleaning. After orthodontic treatment was completed, number 9 and number 10 were extracted. Prior to surgery, and after soft tissue healing, the bone level was re-evaluated in relation to the patient's resting lip position and smile. In a clinical environment, this bone level is determined by fabricating and using a diagnostic template. 3D simulation software helps us gain a more accurate view of our surgical challenges before we begin the procedure. Particularly in this case, from an intraoral view, we would not have been aware of this large defect on number 7, 9, and 10, and that only the number 8 implant was completely surrounded by hard tissue. We believe that when we treat this kind of complex case in the aesthetic zone, these simple yet critical rules must be followed for aesthetic and functional success. In this case, immediate implant placement was impossible, but the other rules certainly apply. Only considering hard tissue support, it would seem that position number 8 is the best candidate for implant placement, followed by number 7. Positions number 9 and number 10 represent the greatest challenges due to a large lid defect around the crestal area. We should place implants in original bone as much as possible. In the aesthetic zone, we should use Pontic as much as possible. So, we decided to place implants in positions number 8 and number 10. Viewing the actual defect, I could see that the lack of hard tissue in the crestal area of number 10 would make placement challenging, but necessary, because we needed to place the implants as distantly as possible to create a natural aesthetic soft tissue contour. The successful selection of an implant site is an important first stage, but this needs to be followed by correct three-dimensional implant placement, along with three-dimensional preservation and augmentation of tissue. In particular, in this kind of large defect case, bone augmentation is the key to aesthetic success. Now, to move away from theory and into the practical. Using a study model or CAD/CAM bone model, titanium mesh can be shaped three-dimensionally prior to surgery. During surgery, the mesh can be easily fixed using micro screws. 8 months after surgery, the ridge was successfully augmented and the tissue was healthy. After removing the titanium mesh, we exposed the regenerated tissue and could successfully place implants in the prosthetically optimal positions. By using technology such as functionalization, we increased the osseointegration of the implants. This added stability and strength is particularly important in aesthetic complex cases such as this, with a reduced number of implants covering a large area and placement in primary regenerated tissue. During the mandibular implant placement, an additional bone graft was harvested from the right lemurs. After placing implants in the number 8 and number 10 positions, the bone graft was placed in the number 9 position. After completing regeneration, we achieved these 4 requirements of the vertical height standard. Aesthetic success requires a three-dimensional approach which uses both vertical and horizontal standards. Using a surgical template for evaluation, we determined that we had successfully regenerated the mid-papillar supporting tissue. In his paper on bone-to-implant relationships, Dr. Grunder found that a target of 4 mm horizontal bone with a minimum of 2 mm was necessary for aesthetic results. The augmented tissue in this case clearly satisfied this requirement. At a glance, these two slides appear similar, but looking at them in detail, we see that the mid-crestal area was augmented both vertically and horizontally. following the imaginary line connecting the peaks of the future papillae. In the near future, I hope to post a video of the previous procedures here at Dental XP. After we successfully augment appropriate hard and soft tissue, it is still necessary to remodel papillae-like tissue contours with prosthetic components. The Barcelona Osseointegration Research Group members introduced me to the following non-invasive remodeling technique. In this case, we used an adhesion bridge to manipulate the soft tissue contour. Non-invasive soft tissue remodeling involves weekly changes in the shape of a temporary prosthesis to modify the soft tissue to the desired shape. I think that this technique should begin with the deepening of a small area, which is then slowly widened to achieve the desired contour. After completion of soft tissue remodeling, an implant-supported provisional restoration was placed. During fabrication of the final prosthesis, CAD/CAM technology allows us to accurately transfer the subgingival contour of the provisional restoration to the final restoration. To establish an appropriate anterior guidance, the bilateral central incisor edge was restored with direct bonding. The patient presented with a very complex condition. This is after tooth removal and tissue healing, but before tissue management. After bone augmentation and implant placement, we had a far more stable ridge to work with, but we still need to remodel the soft tissue. Our final result shows a very natural appearance in the anterior maxilla. The patient also gained improved functionality, including the integrity of the occlusal plane, an angle class 1 canine relationship, solid posterior occlusion, correct overbite, and proper anterior guidance. The lateral views also show an improved occlusal plane, canine relationship, and solid posterior occlusion. On the path between original diagnosis and final evaluation, we must first establish the optimal realistic goal, and then plan and proceed with not only intraoral success in mind, but also considering the overall facial appearance, including resting position and an attractive smile. In the final full-mass periapical X-rays, we achieved a healthy condition around the natural teeth and implants. The easy-to-maintain structure also ultimately leads to long-term health and stability. The patient's self-care was monitored carefully during the maintenance phase, and professional cleaning was conducted at least once every month. This maintenance cleaning period can be extended to once every 3 months if the patient shows evidence of proper self-care. Many of our most challenging cases involved multiple complex factors, including a number of missing teeth, advanced periodontitis with sphere bone loss, and a corrupted dental arch and occlusal plane. Following an interdisciplinary strategic approach in combination with evidence-based use of biologically grounded and clinically viable techniques and technologies, we can restore optimal aesthetics in a complex case. With optimal aesthetics and functionality, we can change patients' lives. Thank you very much for your interest in my cases. I'm excited that there is an increasing interest in this field and would be happy to answer any questions that are directed to me here at Dental XP or directly through my 5D Japan website.